Oh, yeah,
Is
you're
my
fine.
lighting okay?
Yeah,
Just
yeah,
because
it's
I have,
good.
like, an added light just because the light in this room is not that great, so
Okay, no, that's fine. It should be all right.
I don't think people are looking at me, honestly, so I'm just saying.
Nobody listens to this anyway. It's fine. No one's looking at us. No
Yeah,
one's
it doesn't
listening
matter.
to us,
It's
so
okay.
it doesn't matter.
Yeah.
Hello again, and welcome everybody to this episode of the JAFERD cast. I am your host, Dr. Mark Papadakis. Nobody particularly special, just another freaking ER doctor. For this episode, we're going to be talking about vaginal bleeding, specifically first trimester vaginal bleeding. Pregnancy loss, abortion, miscarriage, all those terms you've heard a lot about in the news recently, but may have a little bit of misconceptions about and also questions about too. So one of my colleagues, I went to medical school with, Dr. Tieg Beazer, is going to be joining us. She's OBGYN, we're going to have a good conversation, so let's bring her in here. All right, I'm here with Dr. Tieg Beazer. Tieg, hello. How you doing?
Hi, it's good to see you.
Good to see you too. I think it's been quite a few years since we talked to each
Yeah.
other. You graduated from my alma mater, Toro, in 2017.
Yes.
How you doing?
You know, living the
So
dream.
you're living the dream. I'm living the waking nightmare. It's fine. So after Toro,
Yes.
I see here you went to Cooper actually for residency
Yeah.
in New Jersey, and I'd forgotten about that. And
Cooper
then you did a
University
fellowship.
Hospital.
Okay. And then you did a fellowship at University of Rochester Medical Center. Now, what was your fellowship in?
Maternal fetal medicine, so
Okay.
high-risk pregnancies.
Gotcha. All right. So walk me through, because maternal fetal medicine, I did not realize is actually its own separate specialty, like its own separate fellowship in high risk pregnancies.
Yes. So a lot of ultrasound. So we're the ones who traditionally read your ultrasounds when a person finds out they're pregnant, date their pregnancy, look at their anatomic ultrasounds. If there are any fetal concerns, we'll read the ultrasound, send mom or the carrying parent to the appropriate specialist. We also do consultations for women with complex medical problems in pregnancy, make recommendations. Some people refer to us as like the IM of pregnancy, take care of all the chronic medical conditions.
Did you want to do OBGYN like the entire time you were in medical school? Like, how did that kind of all come about?
I actually really wanted to be ENT, which is so weird because now I'm at
That
the
is
other
weird.
end.
How'd you go from here down to,
I know. I had a reality check with step one and was like, oh, I don't think that's for me.
yeah.
And also then when I went on my rotation, I loved my OB rotation. It was at Trinitas in Elizabeth, New
Oh,
Jersey.
yes. Mm-hmm.
It
Yep.
was thrilling. I liked
Nice.
that there was a little bit of primary care, a little bit of surgery. You can follow patients throughout the course of their lives. You have two patients at once.
And it's interesting that you mentioned that, because in emergency medicine training, we consider, two patients at once, the mother being the primary patient and the fetus, child being the secondary. So,
I agree.
there's a lot of push lately in the news and politics, whatever, with the abortion legislations and all that. How do we reconcile the health of the mother versus the health of the child? And for emergency medicine, it is fairly straightforward in the sense that we prioritize the health of the mother. If you don't have a healthy mother, you don't have a healthy child. So
Great.
our focus is kind of on that. Is that also kind of your world as well? Your
Yes.
approach?
I want to say that it is not that we ignore the baby. Of course not.
No, that's a good point. That's a good point. We don't ignore the baby. Definitely not.
Babies are very important to us, but yes, maternal health is primary because if you don't have a healthy mother, you don't have a healthy baby. And there are also instances in where the health of the baby actually truly compromises the health of mom. We also, not to get into the nitty gritty, but the age of viability is incredibly important. Which varies by institution, but overall is somewhere between 22 to 24 weeks. Usually in the ED, majority of the time, you are seeing patients when they're not even viable, usually.
Yeah.
So that's a factor that is incredibly important and gets overlooked more than we would like in legislature by people who are
Yeah.
not physicians, not
Mhm.
obstetricians.
Yep. Nobody has ever laid a hands on an actual patient before writing some of these laws. So before we get into the popular stuff that's in the news right now, we got to talk about the one thing I want to mention on your resume. It says that you were the face of the New York State COVID vaccine and pregnancy campaign. You partnered with the New York City Department of Health. So when you say that, are you taking your face on flyers? Like, can I actually Google you and you're, smiling on a brochure somewhere? What was that
And
like?
Google me. I was on the subway, buses.
All right.
Actually, where I got my eyebrow threaded in Rochester, they actually had a sign. I don't know why, but it was even there. Yes.
Do your patients recognize you? Well,
No, some have given me weird looks,
okay.
I had that when it was first out. I had people look, and I also did a verbal ad, and my voice unfortunately is unique. If you like to say. So I think people recognized my voice, but they couldn't put their finger on where. So I got a lot of that, but
That's awesome. And you actually, so you worked on a congenital syphilis project for the New York City Department of Health as well.
for 2.5 years, 2 years. Yes.
Okay, so what was that like? How do you get involved in something like this?
Yeah.
Infectious disease and pregnancy. Do they seek you out? Do you just are you in the same room and this is discussed and you just get picked on randomly?
So I actually had a lovely mentor and somebody who is on staff at the University of Rochester, who works on the maternal mortality board, Dr. Christopher Glantz. Amazing human being, taught me many things that I know or don't know, and I ask him on the low. Now, he's wonderful. He actually had suggested me because in 2021/2022, I was pregnant with my first child, and I had received the COVID vaccine in pregnancy in 2020, I had received it in pregnancy during my 2021 pregnancy, and I had also received it when it first came out, like all of us, as a physician on the front line. So they
Okay.
were looking
Before you're pregnant. So, because
Yeah,
I got
before I
mine in
was
December
pregnant.
2020.
Yes. And I had mine, I think, end of December 2020 as well. And then I got pregnant 2021, got it again when I was 20 weeks pregnant. And they were looking for somebody to be the face of this campaign to try to encourage moms to get the COVID vaccine in pregnancy.
Did you have reservations about the vaccine at all? Was that something
Ooh.
that you were cautious about? Did you look at something? Did somebody how did your decision-making process evolve to get the vaccine while you were pregnant?
So fortunately, in between the time that I had got it the first time, December 2020, and by the time that I got it while I was pregnant, a study had come out showing that getting the COVID vaccine did not affect fertility, which I think was monumental in my decision-making going forward. I wanted the vaccine so that I could pass on antibodies to my baby. And I was also working during Omicron 2 masks on delivering women in the ICU who were incredibly sick with COVID. Faces I will never forget were also incredibly paramount in the reason why I got the COVID vaccine. So I'd seen the worst of the worst. I was reading the literature about its safety profile in women trying to conceive and women who were pregnant. And I wanted to give my newborn protection who wouldn't be able to get the COVID vaccine until they were 6 months. So that
And a lot of healthcare workers too at the time, we wanted to be the face of the vaccination campaign in general. So that's why a lot of us lined up to kind of say, hey, this is safe.
Yes.
So it's really important that you actually did that to show pregnant women it was safe too, because I remember that was a concern that we had, and data was coming out slowly but surely. So that's great. That's awesome.
Mm-hmm. And also, as a woman of color too, to try to be the face of attempting to gain trust within the community was really important to me as well.
Yeah, 100%. The patient population that I treat, very unfortunately poor, low socioeconomic status, is a huge underserved community. And I remember at the time we were getting out a campaign to try and push for that vaccination because there is a lot of mistrust in that community that even I see with regards to vaccination and medical treatments. I remember having more than one conversation with my patients, young, healthy patients, whatever, about the vaccine, concerns about either efficacy or side effects. And I remember that was still is in many ways, but a major step to try and get the word out about mass vaccination.
And really quickly, I do want to put this in, even though you're like, nobody even listens to this, but I have to say this. I know that recently the recommendation for pregnant women has been walked back by the government. I don't agree with that. Women are still at a pregnant patients particularly are still at a higher risk to get severe disease. I stand by the recommendation to get the COVID vaccine while you're pregnant. There is a robust amount of data proving that it is safe and effective and decreases your chances of morbidity and even mortality within your pregnancy.
We don't think about this, but pregnancy is considered an immunocompromised
Yes,
state.
it is.
And something that we have to understand is women's bodies are primed from puberty really to carry a child, in the sense that when now a child is developing inside of them, what prevents your own body from attacking this baby? It is a parasite that is leaching nutrients from you, and the body needs to go and say, this is a bad thing for our own self. And it's because the immune system is tapered down. It's not as robust as it usually is. And it's one of the reasons, it's actually one of the theories why women are more prone to autoimmune diseases, because if you have an immune system that is basically overcompensating for the times when they're not pregnant, that's when you can see autoimmune issues. So now you have an immunocompromised individual dealing with a virus that can cause, like you said, significant morbidity and mortality. Yeah, you guys are prime candidates for the vaccine, even though others really don't think that. And your work is funny because your work in infectious disease and pregnancy kind of lends your own unique voice to this too. You see a lot of congenital stuff coming about. You see other issues that people don't think about during pregnancy, namely syphilis. And then all of a sudden a woman gets sick with COVID. What do?
Also, just physiologically, you have a fetus and a growing uterus sitting on your diaphragm, decreasing literally the amount of space your lungs have to expand and deflate. So that makes ventilating you incredibly difficult when you have severe COVID. So yes, people are not, because I have had the privilege of seeing the worst of the worst of the worst in pregnancy. It's a no-brainer. You need this vaccination. You don't want this to be you. But it's hard to tell people. People want to experience it for themselves.
That's right. Yeah, exactly. They want to see what life is on the other side is like, and it's not pretty. It is not good.
Yeah.
Now, have you seen pregnancy lost due to COVID?
Yes.
Have you seen pregnancy lost due to COVID?
Yes. So while I myself was pregnant, yes, I will never forget. It was in fellowship and before that too. But in fellowship, a woman, I want to say she was like in her 30-ish weeks. I can't remember exactly, but I remember.
So late term. We're talking third trimester then.
Yeah. Yes.
Wow.
I remember her face. She had very bad COVID and had a demise. And we had to delay management of the demise, meaning delivery, because she was so sick. It was horrible.
So she had pregnancy loss because of how sick she was, not because of the virus attacking.
She was at home. Yeah, we believe.
Okay.
Please don't come at me. I don't have the autopsy.
But don't at me, bro.
Yeah, no, she was hypoxic, and we believe that had led to the demise. Like she was satting 78% when she came in. So
yeah. I've seen that a lot of times, especially in the first two waves, where patients come in, they're saturating 60, 70%. They're talking to you, but their still oxygen level is so incredibly low. And for people who are immunocompromised, more at risk of severe disease, especially women, that fetus, that baby, takes up a lot of the oxygen. So in a normal pregnancy, we normally see heart rates rise just because the body is trying to get blood to the baby in addition to you. So can you imagine the strain that's undergoing the body trying to get oxygenated blood to both you and the baby in that situation? It's not good. And I can see how it can lead to some pretty bad outcomes. Now, that being said, the virus itself, have you seen a lot of that recently?
No.
It's been 4 or 5 years since really the two deadliest waves kind of came through. Omicron obviously caused another spike, but we didn't see nearly as much morbidity and mortality, death and destruction compared to the first two waves. What about these subsequent waves? Are we seeing a lot of that still now in pregnant women, babies, whatever?
So I will put a disclaimer out that I was not practicing for half of the winter. I started my attending job in December, and I'm mostly outpatient now. So
December of what
December
year?
2024. I started I graduated July, had time off. My contract started December. So I wasn't really in the mix. I will say flu was tough this year.
Yes.
We saw a lot of
100%.
We saw more flu, I would say, like more morbidity from flu than COVID. I would say last year when I was in the mix, and also pregnant. So 2023 to 2024, a lot of flu, not great. We saw a little
Yeah.
COVID, but I would say
Yeah.
flu was dominant the last 2 seasons if it were from my clinical experience.
Yeah, and you're primarily now outpatient,
Yeah.
correct? You're no longer really in the hospital setting. So,
Yes.
and that's been my experience in the ER too, is really a bad flu season. RSV has been bad for the last 2 years as well. Flu has outpaced COVID in terms of the severity of disease, largely for a combination of reasons. You can talk about mutated strains,
Right.
vaccination campaigns, whatever the case is.
Yeah.
But the risk factor for pregnant women is still the same when it comes to a lot of these viruses. It can devastate the person, which can therefore devastate the baby.
Yes.
And that's how a lot of this stuff comes about. I want to switch gears a little bit, and we need to talk about vaginal bleeding, the main topic for obviously this show. Vaginal bleeding does correlate with pregnancy loss in many ways. So people think now, okay, I'm bleeding, I have vaginal bleeding, I'm pregnant, therefore this is likely a miscarriage.
Not
all the time. Yeah.
I get that thought. It's distressing. Absolutely. Yes.
So when is vaginal bleeding a miscarriage? When is vaginal bleeding normal? Are there signs that we can look at? Is there something that women can look to and say, okay, it's, this is likely not a miscarriage, but what should we do here?
You are at home having vaginal bleeding and you're pregnant. You need to seek some sort of medical attention. Please never ignore vaginal bleeding in pregnancy, whether it's you love it's only when I wiped. Don't care. I'm bleeding through a pad. Please see somebody. Whether you're wiping and spotting, bleeding through a pad, you need evaluation for a myriad of reasons. It is never normal in pregnancy.
Yeah, and that's one of the biggest things that women come in and they say, I wasn't sure, I don't know, it was only a little bit, and I'm like, well, doesn't matter. You're getting ultrasound, you're getting blood work, you're getting the whole 9 yards.
Look at that.
This is what it is.
And that's exactly what I would recommend. Yes, there are times where we can't find a cause and everything looks okay, and that's fine, but I never want a person to ignore vaginal bleeding in pregnancy. You need some sort of evaluation.
What is a common cause? Let's say that I have a patient who comes in and they've been spotting a little bit, maybe a little bit of blood, maybe a little bit of cramping, but okay, well, we see a baby in there. Let's say there are 7 or 8 weeks, we see a heartbeat. Now, what can I tell my patients that, well, it could be this, or it's most likely this?
It could be, 1, threatened miscarriage, so threatened abortion. So your pregnancy looks okay right now, but we should follow up in a couple of weeks, especially in first trimester. Not sure what this could lead to. That's number 1. Cervical friability. We see that a lot because the cervix is very soft and sensitive in the beginning of pregnancy. So it's not uncommon to have intercourse and your cervix starts to bleed because it's very sensitive. So that could be a cause. Also infection. It could be chlamydia, gonorrhea, some sort of STI irritating the cervix.
So should I be swabbing these patients now for STIs? Or does every vaginal bleeder get swabbed for an STI?
So that's tough for me to determine for you because then you guys are the ones receiving the results, right? And I'm sure
that's right.
That. Correct?
I want you to say yes, and then you're going to get the hate of every single emergency medicine physician in the country.
I already do. Don't come for me. Don't do it. I know that. But I personally, when I would see a patient in OB triage, when I was a resident, if they had bleeding, I would absolutely swab them. If I saw that they had a swab within the last week or 2 and no new partners and it was negative, I wouldn't probably re-swab them. I would look incredibly closely as well to what I'm seeing on the cervix. STIs can look really nasty. There could be a polyp too, a cervical polyp, a growth on the cervix causing bleeding. Other things that can fool us are hemorrhoids. People think they're bleeding from their vagina, but actually it's a hemorrhoid that is incredibly engorged and painful and causing bleeding.
Yeah, and that's a very common issue that women have when they're pregnant because all of a sudden, now there's increased pressure to your abdomen. There's pressure on your bladder. You can get constipated more easily now. And all of a sudden, you get external hemorrhoids. And this happens obviously much more frequently after and during childbirth and child delivery. But yeah, it's a problem in pregnancy too.
Yeah. And then later on out of the first trimester, probably mid-trimester, so second trimester or third trimester, bleeding is concerning. Are we missing a previa, meaning the placenta is covering the cervix? You have to be very careful when you're examining a pregnant patient saying that they're bleeding. Do you know where their placenta is? Have we ruled out a previa? Just things to be mindful of.
Yeah, and if you think about it logically, right, your placenta is a thing that gives your baby blood, oxygen, nutrients, all that stuff. And usually it's sitting somewhere up higher away from the cervix, right?
Yes.
But now you have it's covering the cervix. How is the baby supposed to even get through the cervix if there's something blocking the way that has a lot of blood vessels in it? And so you have leaking going on there. That also has to be diagnosed ideally before the patient goes to deliver as well, because then they need a C-section. They can't just go right through there. So how is that even diagnosed? What is the usual method for that?
By ultrasound. At your anatomic ultrasounds, we are always looking at the relationship of the placenta to the cervix.
Now, can you see that early on in like the first trimester?
Yes, but many people have previas in the first trimester, and it doesn't mean anything because as the uterus, it's not that it doesn't mean anything. It's not as clinically significant because that's probably the case for everybody. It's as the uterus expands, the placenta kind of shifts backwards. It doesn't literally walk and move, but the uterus expands.
That would be cool if it did. That would be a neat trick. That would be a medical marvel if it did.
I wonder if we would have more rights if it did, right? No, probably not. Probably not, honestly.
Probably not.
So yeah, it wouldn't be uncommon at least 12, 14, 16 weeks to see the placenta coming down pretty low towards the cervix. We become more worried about it when you're in your mid-second trimester.
Okay.
And we still look again in third trimester too. Sorry.
And if somebody has a previa in the past, are they more at risk for a previa later on?
Yes, they are.
So that usually means that they're going to be getting multiple C-sections. If you've had one C-section, chances are good you're going to need a C-section for the rest of your pregnancies, correct?
Not all the time. You can try for a vaginal birth after cesarean section, after one C-section, depending on the indications for your original C-section. So breech, non-reassuring fetal heart tracing, like baby's heart rate drops. Yes, you could try for vaginal birth after cesarean. Times when you cannot TOLAC, trial of labor after cesarean. So times you cannot TOLAC is if you've had a
new one for me too. Okay.
Oh, really? Oh
yeah,
my God,
I've never heard of that one before.
Oh, cool.
I'm just a dumbass emergency medicine doctor, okay? All these fancy terms you're throwing at me, I don't know about. All right, that wraps up another episode of the JAFERD Cast. We had to cut this one short because we have a lot more to cover. Dr. Tieg Beazer, thank you for coming on, and we're going to get her back in here to talk more about first trimester vaginal bleeding, along with miscarriage, ectopic pregnancy, things like that. So we are going to split it up into 2 separate episodes. Already, we talked about getting the COVID vaccine during pregnancy. Women are especially at higher risk during the pregnancy period. They're immunocompromised and therefore should consider getting the COVID booster when it becomes available, if it becomes available. And of course, vaginal bleeding in the first trimester can be normal. However, it should never be blown off and should always be evaluated by a doctor, either an OB/GYN or in the emergency department. As always, I encourage constructive thoughts, comments, and suggestions. You can leave them in the comment section for those on YouTube or email them to me at jaferdcast@gmail.com. If you're in the healthcare field and interested in being in the show to discuss topics in healthcare, or if you have a passing interest in healthcare topics, please feel free to reach out to me as well. Like with anything though, please don't take my word for it. Do your own research, talk to your own doctor, because at the end of the day, like I keep getting reminded at work, I'm just another freaking ER doctor. Make good choices, everybody.